All right, so good evening. Welcome to Kona Science Cafe. Just a preview about what's coming up next. End of January, we have some students from MIT, from the Department of Civil and Environmental Engineering. They're going to be on island in January during what the MIT is called the IAP period, Independent Activities Period. They're going to be doing 2 different projects with some research component, and they're going to give a little presentation about what they accomplished right before they go home. And then in early February, we'll have a robotics, some high school robotics team. So it's the first couple months are going to be students.
Nice.
So that's what's coming up. And today I'm really happy that we have Anna Bershteyn here to talk. She's a colleague of sorts. Until recently, she was in charge of a group inside the larger organization where I've been working for the last several years. Her group was figuring out how diseases spread and how we can fight them. And we are working on ways of keeping vaccines cold out at the very end of the so-called vaccine cold chain in the developing world where electricity is not always prevalent. Anyway, she's moved on to New York University, but she's still an advisor to our group, and I'm really happy that she's coming to the presentation about what she's been doing. Just before we get started, so you have an idea who you're speaking to? I just want everyone go around the room quickly and just introduce themselves, name and background. So just an example, I'm Rod Hinman, and I'm an electrical engineer. Let me just go that way.
My name's Fred Hornbrook. Among other things, I'm a substitute teacher here in the public school system.
My name's Vivian Green. I'm an econometrician.
Here, I'm Steve Jarvis. I used to practice law.
Andre Solomon, computer programmer.
I'm Werner T, software and electrical engineer.
My name is Walter Dimitrenko, and I'm an interested observer.
I'm Suzanne Dimitrenko, and I'm interested in hearing your lecture. We lived in San Francisco for many years and saw a lot of people die of AIDS, and I'd be interested in hearing what you have to say.
I'm Nancy Bauer. I'm a retired veterinarian.
My name is Lee Fauzik. I'm an erstwhile oceanographer and sometimes modeler.
Shannon Mikhail. I'm also in the veterinary profession, married to him, and I'm a product of the public school system in the state of Hawaii.
Dorothy Bowers, my background is chemistry and computers.
Marilyn Hinman, I'm the mother of
Some family visit.
And Cameron Hinman, retired orthopedic surgeon, retired long-distance sailor, and Rod's.
Thank you so much. So it's lovely that we have some mathy, computery, model-y people in the audience, and also people who have been acutely aware of the HIV epidemic in our recent history. So my story, as Rod said, is I've just recently joined the Department of Population Health at NYU, and prior to that I worked at a group called the Institute for Disease Modeling, which is a Gates-funded institute dedicated to mathematical modeling of infectious disease, and I have the incredible privilege of leading the HIV and TB modeling group there. So today I'm going to tell you a little bit about HIV globally, in particular in sub-Saharan Africa. But before I do that, we're in the United States of America today, and as Suzanne said, many of us are very aware of HIV, especially from the period of time where there was no effective treatment, and many people died for a period of time that was the leading cause of death for men in the middle of their life in the United States. And even today, HIV persists as a really important epidemic here domestically, but it's not equally distributed in our society. The lifetime risk of diagnosis for HIV is highest among men who have sex with men in the United States, or MSM, and also quite high among men and women who inject drugs, and quite low among heterosexual men and women who don't fall into either of those groups. I think a number that really sticks out in people's mind is for someone who's a man who has sex with men in the United States, the lifetime risk of acquiring HIV is 1 in 6, so still very high.
Excuse me, could you tell me again what MSM stands for?
It stands for men who have sex with men. So some men who identify as gay and some men don't, but who practice that behavior. And that distribution is also not equitable by ethnic groups in the United States. So for an African American man, the lifetime risk is 1 in 20. And when you look at the intersection of those two for African American MSM, it's 1 in 2 currently. So in the United States, when we think about how do we address HIV, it's about making sure that there's access to prevention and to treatment for those who are positive, but we really can put special attention into certain groups because there isn't equitable risk. And now I'm going to take us to a very different setting, to sub-Saharan Africa, where we have these subpopulations, but we also have something else going on that's driving the HIV epidemic. So let's move ourselves from the United States to sub-Saharan Africa. This is, before we zoom in, this is globally the number of people living with HIV/AIDS. These are 2013 estimates. I didn't have a chance to update this slide, but the picture hasn't changed terribly much. You can see sub-Saharan Africa in pink here. It really has quite a large proportion of the global number of people living with HIV, and the highlighted slice here is just the country of South Africa. So you can see when you look at the global picture, where is there the greatest need for prevention and for treatment in HIV? This is the geography that we're going to talk about.
Anna, what are the different rings?
I'm sorry, so this is one of these nested pie chart things. So the middle pie chart is just by region of the world. The pink is sub-Saharan Africa. And then when you zoom out another slice, it's which part of sub-Saharan Africa. So southern and eastern sub-Saharan Africa. These two slices are the most prevalent part, and then South Africa is a really big slice in southern sub-Saharan Africa. If you go to this link, if you have a chance, you can actually mouse over the different slices of this nifty pie chart online and zoom into different parts of the world. And then this is a paper that just came out in Nature this year, where scientists actually tried to create a much more fine-grained map of where HIV is in sub-Saharan Africa. Here we're looking at the prevalence of HIV. So one thing to keep in mind is you might have heard the term incidence and prevalence. These two words, although they're similar, don't mean the same thing. Incidence means the rate of new infections of a disease. So you often might express incidence as a percentage, like 1% means that if you have 100 HIV negative people, after a year, 1 out of 100 will become infected. And in sub-Saharan Africa, you can see really high incidence rates, like 5%, in some groups even 10% per year. In this case, we're talking about prevalence, and so this deep purple color means more than 1 in 4 people are living with HIV. More than 1 in 4, in this case adults, in these settings are HIV positive. And so you can see that there's a lot of these deep purple areas in southern sub-Saharan Africa, in South Africa, especially in Botswana, parts of Zambia, Zimbabwe, and then also you can see there's a bit of deep purple there in Kenya on the shores of Lake Victoria. So there are different parts of sub-Saharan Africa. It's certainly not equally distributed. And then also when we look at sub-Saharan Africa, in this case we're just looking at the country of South Africa, we can also see that there are different patterns within the population. So here we're looking at age pyramids, which if you've ever looked at demography papers, this is a very common way of looking at the population, where you see men on the left and women on the right, and then this is by age group. And here we're looking at the number of new HIV cases, the total number living with HIV, and the total number of deaths. And then I'm just going to flip the slide and give it to you. This is just total numbers. This slide is proportions. So this is incidence, like I told you before, the rate that people become infected. This is prevalence, the proportion of people, and then that last one is mortality rate. And so the difference between this and this is, you can see when we look at it at a rate, it becomes more bottom heavy, and that's just because there are not as many older people as younger people in the country. And so when we look at absolute numbers, we see a lot more younger people. So that's one trend that we can see. There are very high rates of HIV, in part in these younger people because there are more of them. The other thing that we can see is that there's a difference by gender. And so in men, the rates of HIV are lower, and they're a little bit older than women, shifted by about 5 years. The number of people living with HIV, there are many more women than men. But the number of deaths, you actually see that trend flip, and you see more deaths among men than among women with HIV. So that's a really interesting pattern, right? Can anybody think about why it might be that you see more new cases and more cases of HIV in women, but more deaths in men? Yeah, go ahead.
The women are seeking treatment?
That's exactly right. So women tend to be diagnosed sooner. One reason for that is because it's customary to test for HIV when pregnant women come to clinic, and that's done for the health of the baby, because if the woman takes preventative treatment, it can prevent transmission to the baby, and now it's also considered a way to diagnose a woman for her own health, so she can get on treatment for life. But even when you neglect the fact that women get tested through antenatal care, even other forms of testing are more frequently visited by women than by men. It's very challenging to engage adult men in care in these countries where it's not common to go and get your blood pressure checked every year. Most people, if they're healthy, they're not going to see the doctor for regular checkups, and it's just very challenging to recruit men. Yeah.
How is it that the incidence for women seems to be much higher overall than for men? That's surprising to me.
Yeah, it's very surprising, and here are some of the reasons why. So one is, as we saw with the United States picture, men who have sex with other men can transmit to one another. As best we know, women who have sex with other women don't transmit to one another. And the rate of intravenous drug use, which is another way of a form of HIV transmission, is not very high in these countries. So something very different is happening. HIV is being transmitted in heterosexual couples, and more women are getting it than men. So that's telling us that there's something very important happening in the networks of how people's sexual partnerships with one another that's causing women to get a lot of HIV, with men being a critical point in that transmission chain because they're not getting it from other women. So then that's what we'll get into that. That's really the interesting basis for mathematical modeling to try to understand what's going on. But the other thing, Rod, in addition to what you said about more women are seeking care, we now know that people who get HIV treatment are less infectious, and if they're very adherent to their treatment, they can become completely uninfectious to their partners. So what does that do? That prolongs life for women. It reduces mortality for women. It also reduces the rate of new infections for men. So it's reinforcing this pattern. And then yet another thing that's reinforcing this pattern is there were about a decade ago 3 very large trials that showed that men who become circumcised are 60% less likely to acquire HIV. And so that's been one of the public health responses to HIV, was to offer free circumcisions to any men who want it in these settings where there's a lot of HIV. That reduces the rate of new infections for men, but it doesn't reduce onward transmission to women. It only protects the man, not his female partners, if he becomes infected. So that even further reinforces this pattern where we're seeing this gender difference. And then the age shift, we think, is primarily because in general it tends to be an older male partner and a younger female partner, as it is in many parts of the world, and that might explain part of this trend. So that's what we're observing in terms of the HIV epidemic. This is becoming a slightly dated slide, just reminding us all of the gravity of the HIV epidemic. In the 1990s, it ranked not terribly high in terms of global causes of HIV. In 1990, by 2013, it became a leading cause of death and disability globally, and thankfully now it's declining.
Could you explain this slide?
Yeah, so this is just a ranking of, in the world, what are either the causes of death or causes of disability. And when you measure, so you'll notice one thing, the number 2 thing in 1990 and in 2013 is low back pain, which people find sort of strange because it's not often a cause of death. But there's a way that scientists try to compare conditions that cause disability but don't necessarily cause death versus conditions that cause death. They actually ask people either with the condition or people without the condition, would you rather live an additional 5 years, or would you rather live the rest of your life without any low back pain? And so then they're able to rank different causes of death and disability. And this slide is just here to remind us that in 2013, HIV/AIDS was #1 globally, and it still ranks very highly. I need to update this slide also to get the current rankings. And just to reinforce again, HIV/AIDS is, the mortality was so high that it actually imprinted on the demographics of these settings. And something that we only really see in human history in the context of major epidemics or wars is life expectancy decline. And often, some of the only times where we see very rapid increases in life expectancy is actually at the tail end of epidemics, right? Otherwise, life expectancy is increasing, but only very gradually. And so the picture, this is a community in South Africa that was one of those deep purple, 1 in 4 or more people infected with HIV. And this is the adult life expectancy in that community. So you can see it sort of reached its worst point in 2004. And this was right around the point when treatment began to become widely available in sub-Saharan Africa, in South Africa, and was rolled out more and more. And then you see these huge increases in adult life expectancy as treatment became available. And then this other graph is just showing how long can a person expect to live in one of these communities if they have no HIV in green, if they had HIV in 2003, and then if they had HIV in 2011. So you can see that there's still a gap, but that the picture has really changed, and you're seeing these big increases in life expectancy because of HIV treatment. And this is a similar, I think I'll skip over this, but this is a similar sort of graph showing mortality rates over time, HIV coming in and mortality rates just surging in adults between the ages of 15 and 45, when it's pretty rare for an adult to die of any cause. Suddenly you see mortality in that age group surging. And then this is showing where in the world that mortality is happening. So just reinforcing that HIV is not a very specialty question, that it really impacted mortality rates across all causes globally as a pandemic. So we talked just now about how the expansion of HIV treatment caused these huge increases in life expectancy in sub-Saharan Africa. Well, where did the resources to do that come from? Well, it turns out that HIV/AIDS is also historically the greatest charitable aid area in history. And that's quite warranted, as you've just seen, because it was such a threat to humanity, to society, in these areas where prevalence was high. And so this is showing where international financing for HIV is coming from. Again, you can look at this website where you can actually mouse over and see where the aid from all different sources is flowing to different countries and into different areas. But this is the overall picture. The United States, as you can see, is a very major donor in HIV/AIDS. Yes.
And has that changed at all in the last 3 years?
So international aid for HIV has more or less flatlined in the past 3 years.
But what about in America?
And in America as well. So it's been this interesting dance with the current administration, because on the one hand, we want to see progress, right? We want to accomplish amazing things in HIV/AIDS, and we have to remember it was a Republican president, President Bush, who created the President's Emergency Program for AIDS Relief, which was the beginning of this massive AIDS. So that's always been a non-political, bipartisan issue that everyone can agree upon, that it's an amazing thing that the United States is doing. But on the other hand, in the climate that we're in, it's not likely that there's going to be a huge surge in international aid, at least currently. And so the real challenge lately has been, can we make the major progress we want to make without an increase in resources above what there exists today? And so that's really where the creativity in the HIV field has been in the past few years. Given we have more or less a flat budget, how do we stretch our dollar? How do we get more people on treatment with the same amount of money? And there are neat approaches that are being rolled out in sub-Saharan Africa that hope to approximately double the number of patients in care within the same amount of resources. And that involves creative things like, rather than a doctor prescribing medication or even a nurse prescribing medication to a patient, having groups of patients in the community meet together and talk together. Is anyone here having symptoms? Does anyone need to go to the clinic? Is anyone having trouble taking their medicine? And then just having one delegate from that group, and they rotate through, go and pick up the medication for the clinic, from the clinic. So trying to get the patients more involved, or people at the community level, lay workers, or at least kind of minimally trained nurses doing more and more of the care, so that we can deliver more within the same budget. And also trying to subdivide which are the patients who really need to be seeing a highly trained specialist and which are the patients who are doing fine and who don't need that much interaction with the health system. They just need to keep getting their medicine. So that's been sort of the trend of the past few years, given the flat budget.
I see 70% and $7.5 billion. Is that the United States share? So the worldwide is like 11 billion. And that's relatively flat.
Yeah, we're in an interesting place right now where there are different, in addition to, there's bilateral aid, so this country agrees to give that country some amount. And then there's also these large funds. So HIV receives funding from the Global Fund for AIDS, Tuberculosis, and Malaria, where different countries pitch in, and then that funding flows to different countries that need AIDS. There is also a Global Polio Eradication Initiative. That's another collective of donors like that. There's also a global access to vaccines. It's called Gavi, the Vaccine Alliance, but it's about paying for childhood vaccines. And so for each of these funds, so it's a little confusing, and that's why you have this interesting picture that countries can donate bilaterally, and then they also can pitch into these big funds that then donate to countries. So what can we do with that funding to prevent HIV? Well, we already talked about how we can give people treatment for people who already have HIV, and that makes them not infectious to others. And then for pregnant women, we want to make sure that they don't transmit to babies. So even if they're not on treatment, they should get some kind of therapy to prevent transmission to the baby. For people who are HIV negative, we talked about how men can get circumcised, and that reduces their rate of acquisition by 60%. It's thought that it doesn't affect their rate of transmission, so there isn't a benefit in this sense to men who are HIV positive already. And there are new things that are being rolled out for HIV negative people. For example, we PrEP, which is actually quite widely rolled out now in the United States to high-risk populations, which is taking a pill, someone who's HIV negative taking a pill every day to prevent getting HIV, which is being rolled out in sub-Saharan Africa. Kenya is the first country to provide that through their public clinics, and there have been a lot of pilot and demonstration projects in other countries trying to figure out how to do this in a way that people will accept and that's cost-effective. And then there are experimental vaccines. There's a large vaccine trial going on right now in South Africa. And then there are things that are both for people who are HIV positive and for people who are HIV negative. So treatment of other sexually transmitted infections, providing condoms, providing regular testing and counseling, and trying to promote behavior change are some examples of things that are for everyone.
What company is involved in the experimental vaccines?
That's a great question. So there are two different companies. One of them manufactures a virus that has an HIV gene inside of it, and the other company manufactures a protein that comes from the HIV coat. And actually there was a trial that just looked at that protein from the coat that didn't show any benefit in terms of reducing the rate of HIV, but immunologists think that the combination of the two might actually have an effect. A decade ago, there was a clinical trial in Thailand which showed that that combination could reduce the rate of HIV acquisition, but only by 30%. So not very impressive. And that was for the subtype of HIV that's more prevalent in Thailand and in the United States and in Europe. But now there's a new trial in South Africa that's for the subtype of HIV that's prevalent in Southern Africa. And the trial's still underway. The scientists don't know if it works or not, but what they have observed is that people who get the vaccine have a really nice, strong immune response, even stronger than the people who received it in Thailand. So we're all keeping our fingers crossed. The Thailand was about 30% efficacy. The thought is if in South Africa, if it can get to a 50% efficacy or better, maybe it's a real product that might be worth it.
And who are the companies?
I will see who ends up commercializing it. It's a little bit of a complicated question because the protein is no longer being manufactured. I believe they're kind of using protein that had been manufactured after the Thai trial. So we'll see what the commercial partnership looks like. The first question is it a product? And that's a really challenging question too, because the vaccine as it's currently being done is 8 different injections administered over 5 different visits. And it's likely that the benefit of the vaccine will wear out and wane over time. So you can't, for example, South Africa has rolled out HPV vaccination to 9 to 11-year-old girls, and they're doing it through the schools, which is a great way to reach a lot of people, but you can't do it with a vaccine that wears off that quickly because the peak age for exposure is much later. So there are a lot of questions to be addressed. Who's going to make it? How are we going to get it to people? How are we going to get people to stick to this really complicated regimen of injections? So with all of that background, all of these interesting questions and important problems, why use mathematical modeling for HIV? You probably have a lot of ideas already. One is we want to generate hypotheses about why it's so endemic in southern sub-Saharan Africa. That's not actually really known. What's so different about that part of the world? And maybe if we can understand what the underlying drivers are, then we'll find a way to halt the epidemic. The other is to understand if we're measuring the right things, and are the things that we're measuring really consistent with one another. So it's about, when I say prevalence is 25% here based on a survey that was designed in a certain way, and then someone else says incidence is this much, does all that information actually hang together and make sense? And then finally to propose how interventions should be rolled out to interrupt transmission. And the particular type of modeling that I've specialized in for this purpose is called agent-based modeling. So some of you have probably encountered some kind of mathematical modeling, and in epidemiology, what you might do is write some equations. So you might say, let S represent the number of susceptible people who could get the disease in the population, and let I represent the number of infected people. And then maybe if it's something like measles that people can recover and become immune from, we can let R represent the number of recovered people. So that's what we call the SIR model in epidemiology. It's sort of the first thing you would ever study if you open an epidemiology book, and you can write down some very simple equations for, ds dt over time equals this, di dt over time equals that. So when you write these models that are simple like that you can write in your notebook, often what you're doing is you're assigning variables to categories of people. So S is not a person in your model. S is a number. It's a number of people who fit into a certain category. Now, agent-based modeling is very, very different from that. With agent-based modeling, it's sort of like SimCity. You're actually modeling individual people, and in the computer, rather than a variable representing the number of people like this, you allocate memory for each person in your society, and you have those individuals interact over time. So this is a really neat way of modeling, because you can have complex phenomena that arise from relatively simple rules about how these agents behave with one another. So this is an example of what I talked about SIR as being the first thing you might learn in epidemiology. Well, in agent-based modeling, you take that notion that a person could be susceptible or infectious or whatever, and you put that inside the person. And you have that person be represented in memory with their disease state unique and internal to them. And what's kind of neat is this way you can have many different possible disease states. Maybe not just 3 SIR. Maybe there are millions, maybe there are trillions of different possible disease states. But because each person is assigned their particular disease state, you can simulate that population without having to simulate every possible compartment. Right? Because sometimes there are more, and this is probably true of all of us humans, if you look in enough detail, there are more hypothetical possible humans than there are actual humans on Earth, right? And so we don't need to represent every possible empty state of every possible person that there could be. We only need to simulate those of us who are actually here to represent society. That's the underlying idea of agent-based modeling. So we have these people, they can do things, they can migrate, they have their population dynamics, they're born, then they die, and we erase them, we can reuse that computer memory for something else, and they interact with one another. So we created this mathematical model, and that's agent-based. We actually used it to model all kinds of different diseases, including HIV, which is sexually transmitted, vector-borne diseases like dengue and malaria transmitted by mosquitoes, environmental diseases like polio and typhoid that are fecal, oral, and contaminated water. and then airborne diseases like tuberculosis. And something that we learned along the way in just the process of writing this software, the reason why people don't often do this kind of modeling, people tend to prefer the equation-based compartmental models, is it takes a lot more effort. But as it turns out, a lot of that effort goes into basically bookkeeping. So saying, hey, there's a person. Don't forget to allocate memory for that person. Don't forget they need a unique ID, and you need a pointer to that unique ID, and you need this, and you need this. All of that gets to be quite cumbersome. And so what we learned was just the common framework in blue here, the code that is shared by all of these different diseases, is most of the work of creating a model like this. And once you've created it, the additional code to say, oh, also I'm simulating a mosquito-borne disease in this crosshatch. Let's add mosquitoes to the model and make sure they're the ones transmitting the disease. It's not that much more code. And in fact, the dengue model here, it was done by a completely different group at the University of Notre Dame. And they took our malaria model, got rid of the malaria part, and put in dengue instead. And all they had to do was that little bit of extra code in blue. So something I've really appreciated it was the chance to work with people who work on all kinds of different diseases, but being able to all share code together so that all of this part we can do together and do a great job and fix one another's bugs and add bells and whistles for one another. For I know there's at least one computer programmer here, something important in designing the code this way is that you can use inheritance, which means you can create an object that is a person, and no matter what the disease is, people will always have a date of birth, and they'll always have a gender, and they'll always have a location, and they might know who their mother is, and they might know who their children are, and things like that that all people do. And then you'll layer on top of that something like, oh, and the disease that we're interested in is transmitted by some kind of vector, like an insect. Or the disease that we're interested in is transmitted sexually, so also people have sexual partners, and they might remember who their sexual partners are, and they might be able to use condoms. And no matter what the sexually transmitted infection is, everybody does that. And then you just have to add that little bit more to say, and the disease is HIV. And so we have these specific treatments or the specific biology. So this was a really important thing to let us build a model as complex as this. So just to tell you a little bit about this particular HIV model that I built, or that the team that I worked with built, one of the really, really cool things was we got to work with scientists as well as professional computer programmers, which I had done my PhD in academia. I didn't know a whole lot about professional computer programming. How do you write software well? How do you test software? How do you make documentation so anyone else can use your software? So it was just awesome to work with people who know how to do that really well. And so the model includes demographics. So who are the people? What's the rate at which they are born and die, and where do they live? Information about their contact networks. So this is now at the level of a sexually transmitted infection. Who are their sexual partners? How long do their relationships last before they might dissolve? The biology of HIV. So how long do people live with HIV? What happens to their T cells and different things with and without treatment? And then I think most importantly, we put a ton of detail in the model about how people access healthcare. So do women get tested when they show up because they're pregnant for medical care? Or are people getting tested in other ways? If they're tested, what's the probability that they will go and get on treatment? How long will they stay on treatment? That's where most of the questions were from people who work in sub-Saharan Africa. So we put a lot of detail and a lot of flexibility into the model in that part of it. So this is a little bit about the sexual network. So we have a way, we put in an algorithm that makes sure that when you look at the sexual relationships in the simulation, they actually look like the sexual relationships that people see when they go and do surveys in sub-Saharan Africa. And so again, in this part of South Africa, people went door to door and they asked people a questionnaire which included, tell us about your sexual partners and how old are they relative to you. And so we had to make sure in the model that we paired people up in sexual relationships that actually looked like that. And we also had to look at the studies of the biology of HIV. So there's some data sets from before treatment was available. And so we could look at the natural history of infection. How long can people survive with HIV before treatment became available? And there's a lot of data now that treatment is widely available about its benefits of extending life. we'll skip this. This is just an example of simulating individuals in our model and looking at how their T cell counts change over time and how does that compare to different data sets. And then I think this is the part that is the most interesting about interacting with this model. So the code gets complicated, and complicated code can be really hairy and hard to work with. But something that we thought was really, really important was we wanted to be able to simulate different ways of distributing healthcare, different ways of reaching populations with health interventions in a really flexible way in the model. Because we wanted somebody to be able to say, aha, maybe if we delivered our care this way, maybe if we drove a van around and we offered testing to people in the community inside of a van, or maybe if we found everyone who had symptoms of AIDS and then we tested their people in their household, or whatever it was, that we would be able to quickly and easily use our model to say, this is what would happen if you did that. And so we were constantly going in and rewriting the code for this, and it became pretty unwieldy. And so the programmers that I had the chance to work with on this developed a way to take that aspect of the model and put it completely outside of the model code, to where now there's something that basically the user can write a flow chart to say, this is how people go through the different steps of accessing care and staying in care. And then the model can implement that flow chart within the population. And it's almost like Legos, where you design the Legos of, this is a person being tested with this kind of a test. And if they test positive, they, with some probability, might connect to this next step in care. Maybe they'll get their T cell count checked. And then you decide how those Legos connect to one another. So that was it's something that taught me a lot about how to write software that you can reuse again and again, was putting in this part of the model. And some of those Legos included, like I said, treatment and circumcision. It also included delays. It turns out it's really important to capture how long does it take. If somebody just got their HIV test, how long does it take until they can, someone can run the labs and get their result back to them, or put them on the treatment that they need. And so we made sure that people could play around with, what if we could shorten this delay, or what if there is a delay here? How important is that to the HIV epidemic? And then diagnostics, like testing for HIV, and also decisions and differences across the population. So these are just some examples of ways that people could create flowcharts. The one on the right is if a woman is pregnant, and what's the chance that she'll actually get an HIV test in the clinic where she's getting her prenatal care. And then if her HIV test is positive, is she going to be offered something? And then there's a whole bunch of, early on, women were given just injections of a single drug called nevirapine to prevent transmission to the baby in labor. But now we know that they need to be taking oral pills, and in fact they should keep taking those oral pills even after they deliver while they're breastfeeding, to prevent transmission during breastfeeding, and ideally for the rest of their lives. So all different things might happen to that woman from that point, and we wanted to be able to create these flowcharts like Legos so that we could say what would happen if we made this part of the health system better. This is a simplified version of the entire Lego castle that we built with this system, and that we were able to run within the model to represent all the complexity of the health system in South Africa for people who are living with HIV. So finally, that was sort of my software development journey in creating an HIV model. I wanted to give you a taste of some of the research that we've done with this model so far. And I'll also point out that the code is public and it's available, and really our intention is we've done some research with this, but I also have had the chance to mentor students at different universities, including universities in sub-Saharan Africa, and increasingly people who are working within health systems in sub-Saharan Africa. And so really we're hoping that it doesn't end here, but that other people will use this software to ask and answer questions.
Is the WHO and the CDC using the software?
So they're not, there isn't anyone using it directly. We've done some trainings within USAID, within CDC, but primarily it's people either in academia or people working in NGOs and things like that within sub-Saharan Africa who have been using it. Yeah, it's interesting interfacing with some of the government agencies, and how technical do they want to be in terms of running models versus would they rather just pay somebody who's a modeler to go and answer their questions.
Is the code available on GitHub?
Yes, it's available on GitHub. One of the questions that we asked is, so first of all, I should say, when we were building this model, we were kind of nervous because when you query people in sub-Saharan Africa, how many sexual partners do you have, and how old are they, and how often do you have sex with them, and you get all these numbers, you're not sure if they're telling the truth, right? Maybe there's some big piece of the picture that you're missing. And so we put all these data into the model, and we thought, what if we don't even get an HIV epidemic when we just take these data for the most part at face value? We allowed for uncertainty for reporting, but we were worried that what if we're just completely missing the picture? And so the first big relief was when we put all that information into the model, we actually got an epidemic that looked more or less like the epidemic in sub-Saharan Africa. And so then we were able to look within it and say, who's transmitting to whom? You know, are there tricks we can play? Can we get the epidemic to age out of the population somehow? You know, what are the most important links in the transmission chain? And so we've done a bunch of work on that you can read some of the publications on, just about the patterns of transmission. One of the ways that we used that work was to say, could you create what in the vaccine world is called a ring fence? So at the end of smallpox is the only human disease that's ever been eradicated, wiped off the face of the earth. And one of the things that was done is if there was a case, people would vaccinate all the contacts of that case all around and call that a ring fence to prevent it from spreading beyond. And so we thought with HIV, could you create sort of like a ring fence, either by vaccinating a cohort or by vaccinating everyone within an age group to sort of create an AIDS-free generation after that cohort. So if we vaccinated everyone born, you know, within some window of time, and that group is aging through a population, in this case, it wouldn't be vaccinating, it would be trying really hard to get everyone on treatment and maybe giving prophylaxis to people who are at risk of becoming infected. But could we sweep HIV out of the population by doing that? The answer turned out to be no, for a few reasons. One is there was, at least at this time, still enough transmission from mother to child for the epidemic to skip a generation. Another is that there are intergenerational sexual relationships, and they're common enough for this kind of a strategy not to work, sadly. But these are the kinds of things that we started thinking about with the model. In particular, we asked about, are these potentially intergenerational relationships underreported, and does that matter? We also asked about particular populations that there's been a lot written about, in part because they were founder populations for HIV. So HIV is very prevalent in rural communities in sub-Saharan Africa that people think got HIV because there were migrant workers. In South Africa, for example, people would go and work at the gold mine. There were a lot of sex workers in the area of the gold mine, and they would bring HIV back to their communities. So we started asking, can we zoom in on some of these populations and try to get a big effect on the epidemic by really focusing on populations that matter? It turns out it's too late. The gold mine strategy would have worked in the 90s, but it's too late for that particular strategy. And then you mentioned the World Health Organization. Although we don't, though WHO isn't running our model, they tend to have others run models to answer their questions. What we did do was we participated in a collaboration of a whole bunch of modelers focusing on HIV to advise the World Health Organization as they made different recommendations. So over the past decade, the WHO has changed the guidelines about who should be getting treatment among people with HIV. And at each of those revisions, we had the opportunity to chip in. This is what the models say about the impact, the cost effectiveness, why it would be beneficial, or what are the different trade-offs? What would happen if you took the resources you would use to do that and spent them doing something else? Is there a better idea? And then finally, being modeling nerds, we ask a lot about which parameters matter the most. Are we making our models correctly? Where do we need to pay more attention in the models about getting it right? Where does it not matter so much and we have way too much detail and we need to focus elsewhere? And so we do a lot of sensitivity analyses, is what we call it in modeling, where we say this, measuring this number correctly matters a lot, and it would really change the picture in terms of what you should be doing to combat HIV/AIDS. And then we can give that information back to scientists and say, you should run a trial to measure this really, really well because it matters a lot. And we also give feedback to ourselves about where we need to improve. And then, I forgot that I included this piece as well. We also test ourselves. Are our models any good? one of the big privileges as a modeler that I've had was being able to work with a clinical trial. So in a clinical trial, researchers have an intervention group and a control group, and they're testing a hypothesis and they have an outcome. But in order not to accidentally bias the study, what the scientists do is they blind themselves to the outcome until the end of the trial. So they might not know who's getting the intervention and who's getting placebo until the very end, and then they decide ahead of time what the statistical analysis will be, and then they unblind the study at the end. So something really amazing was we got to test our model in that context. So the scientists were able to say, this is what our intervention and control, in this case it was community level, not individual, so control communities look like. Can you guess what the outcome of the trial will be before we're even allowed to know it? And so we've done this in the context of a clinical trial. We've also collaborated with other modelers to try to predict surveys ahead of time. And I think this is, knowing that the model has some validity is super important if you're going to go to a government and say you should do more of this or less of this. So that's also a very big part, probably the majority, I would say, of what we do. So here's just one simple example of a question that we tried to answer with our model that we felt was valid. And the question was, why are people dying of HIV/AIDS now in a world where treatment is free and it's available widely in sub-Saharan Africa? Where are we failing? Where do we need to work harder? And so with our models, we looked at how many people died because they never initiated treatment. That was almost everybody before treatment became available in the mid-2000s. How many people died because they initiated treatment, but they presented for care so late, their T-cell count was already so low, they couldn't be rescued by the treatment. They should have started earlier. How many people started the treatment, but either they didn't take it regularly, or the strain of the virus that they had was already resistant to that treatment, so the treatment failed. And then finally, how many people started treatment, but then they weren't able to continue and they stopped coming? And what our model ended up telling us is that those people who never initiated, they were and probably still are a majority of HIV deaths, but we're expecting that by 2030, that will not be the majority of HIV deaths anymore. We don't think that late presentation is going to become quite a rare thing because people will be testing much sooner. Treatment failure, thankfully, is not going to become very common either because drug companies keep coming out with newer drugs and drugs that are very different from existing drugs, which will prevent the virus from becoming resistant to what we're giving people. But the loss to follow-up is going to become the major reason why people still die of HIV, because it's hard to keep taking medicine every day for life. And so that's what our model is telling us, and it's helping people think about how can we support people to adhere to therapy for life, because it's going to be our highest priority issue in the future. So that's a little taste, yes.
When was this agent-based modeling begun, and who funded it?
So it was funded by Bill and Melinda Gates through this program called Global Good, which is also the program that funds Rod's work on the cold chain for vaccines. And it began in 2010. So I had the chance to be the founding member. It was what I did straight out of my PhD. I defended my dissertation and my start date was 1 week later. and yeah, it was just an incredible privilege to get to recruit a team to work on the HIV and TB model.
And how many people were involved in developing this agent-based model?
So we were about 3 researchers on HIV specifically, but we were working within an institute that now is 100 people, and it includes professional software programmers, testers, documenters, and then all of the people who work on the other diseases, malaria and typhoid and this and that. We all end up sharing resources. Is Gates Foundation still funding? So yeah, the institute is still going. It's funded by Bill and Melinda Gates, but it's not a grantee of the Gates Foundation. The setup is a little bit different. However, I just recently moved on to NYU, although I still work very closely. Still have a big space in my heart for this place that developed this model because it was a really big undertaking. Yeah.
So at the end, you said that the major amount of people that are going to be dying is because they don't continue their daily treatment. Are there any, and there's companies that are doing, and scientists that are doing research for immunization and vaccines to prevent HIV, but is there anybody who's doing any kind of drug therapy that would not involve daily doses and maybe be, something that they could take once a month or intravenously or less frequently to help with that?
That is an outstanding question. And I think at this point, many people believe that that is the future of HIV therapy. So there are a few, the really big thing that happened in recent years was drug companies have discovered drugs that are very potent, meaning that rather than taking 100 milligrams a day or several hundred milligrams, you can take a few milligrams a day. And so that means you don't have to have a huge amount of that drug that would last a month or multiple months. And now companies are developing injectable formulations to where you can get an intramuscular injection similar to a vaccine that will have all of the drug that you need for hopefully a few months at a time. So that's, I know they've run into, there is one of those regimens that was evaluated very recently by FDA. I saw it on my newsreader, and the FDA sent it back and said this is not ready for clinical trials yet. So there'll be some back and forth. But I think there's a lot of it because there is HIV in the United States and people who don't want to have to take a pill every day, there's a market here. And so it's actually quite a good situation. In some cases, companies have these agreements where they'll sell it at whatever price they're going to sell it at in rich countries, but they're going to sell it more or less at the cost of production in countries that couldn't afford it otherwise.
So was it your model that helped influence the change in therapy?
So the drug companies are the reason there's so much activity in this is because there's a market here in the United States. So I think that's really the driver. But it's awesome that countries in sub-Saharan Africa can benefit. And one of the things Gates Foundation has been very active in, as well as anyone who's funded by them to develop something, they have to adhere to something called global access, which means make your money in the rich countries if you want to, but for the poor countries, you need to make it available for 10% above the cost of production. So it didn't take a model that was sort of, they are very financially incentivized to do that.
I'm not sure quite how to word this. Is this an operational model that is used to make predictions at this point and to come up with actionable things to do? I mean, is it kind of routinely used, or is it still captive of academia?
Yeah, we put the code up on GitHub in mid-2015, so it's been out there for a few years, and so these past few years have been about actually using it in ways that are meaningful and useful to countries. And so I've just joined NYU 3 months ago, but 4 months ago now, wow. One of the things that I hope to do more is actually engaging with people in the ministries of health in these countries, or people working closely who are kind of the technical people who support members of the Ministry of Health, to make sure that I'm not answering my questions or some academic question, I'm answering their questions and their priorities. I think that's a really critical piece there. Building the model is hard, and I've told you a little bit about what we've overcome there, but the most important thing is that you're actually addressing what the health authorities need addressed in these countries.
I've worked in 2 developing countries, in Nepal and Thailand, and what comes to mind for me is giving females access to education, giving females access to healthcare, and ensuring that females have equal rights to males in whatever country you're talking about, so that women are free to resist sexual advances of men that are unwanted. Also, it seemed to me historically that if electricity were provided to people in outlying areas, that would be helpful, because there would be something to do in the evenings other than to go to bed early. But now it's not so much electricity, it's more satellites. because we don't need to plug something into the wall anymore to get a radio or a TV or whatever. We just need to have a satellite connection. So that's what I think of from my experience.
It's amazing. The HIV problem is so big that scientists have actually been able to run some experiments to test some of these hypotheses. So there have been studies of unconditional cash transfers, which just means we're going to basically provide welfare. We're just going to give cash to families that have young girls with a high rate of HIV, and then we're not going to do it for other families. We're going to see if the HIV rates are different, as well as conditional cash transfers, meaning, for example, you'll keep getting these transfers into your bank account as long as the girl stays in school, or as long as the girl stays HIV negative, or whatever the condition is. And so far, there have been very mixed results about whether these very targeted interventions can reduce the rate of HIV in terms of purely from a scientific, causal relationship. But I think more broadly, of course, everybody, HIV is a health threat, but there's so much more going on in these settings, and everybody wants to lift people out of poverty, to help women become more equal in society. It's just, as a scientist, it's a little bit confounding sometimes because, for instance, when you look at the relationship between HIV and development, economic prosperity, it's easy to think about this must be a disease of poverty. And if people fall into poverty, they're more likely to get HIV. But that hasn't really been the relationship that people have seen. For instance, during the economic collapse in Zimbabwe, there was actually less HIV. And maybe it's because men had less cash and were less likely to go and see sex workers, or we don't really understand the causal relationship why, but it's complicated. But it's, there's no question that whether it benefits the fight against HIV or not, those are really worthy things to do because it benefits people.
What motivated you to move to NYU?
Primarily family, but I'd also graduated from MIT, and I'd only done one thing for a decade, which was working on this model in this institute. So it's nice to try something different, work among different people.
Are you also teaching as an assistant professor?
I'm not yet teaching.
But you will be.
Yeah, I think I'll get to do some teaching later on, but my institute has been very kind to me so far, so I've just focused on research since I arrived.
This might be a little far afield, but when you were talking about the other people focusing on other diseases that could use parts of the code, didn't mention Ebola. Is that in there somewhere, or is that such a totally different animal that it is a totally different discussion?
Yeah, so this particular code base, we didn't end up implementing Ebola within it, although that 100-person institute that I worked for did end up doing some work on Ebola. But it's, it could in principle be added to the code base. As you probably noticed, many of the diseases that were listed, HIV, tuberculosis, malaria, they're ones that just have a high total burden in the world. So in the height of the West African Ebola epidemic, the rate that people were dying, if that rate had continued on, it would have become a really terrible chunk of the global burden. But when we look at, how many people die versus Ebola versus how many kids die of malaria every year, right? So we ended up focusing on the really big slices.
Okay.
All right. Thank you.